evening and welcome to this public briefing of the Standing Committee on Social Development. My name is Jane Wayellen Armstrong and I am MLA for Mofi Kloochie Region and Chair of the Standing Committee on Social Development. I will now ask members in the room to introduce themselves for the record and followed by those online.
Thank you, Madam Chair. Good evening, Minister and staff. My name is Danny McNeely, and I'm the MLA for the SAW2.
Good evening. I'm the MLA, George Nearsu, MLA for the Mackenzie Delta.
Okay. Cheryl?
Good evening and thank you. My name is Cheryl Yakla. I am the member for the Det'anchogh.
Shauna?
Good evening. I'm Shauna Morgan, MLA for Yellowknife North. Apologies, I couldn't be there in person. I'm not feeling well this week. Thank you, Mussy.
Introduce yourself, Kieran.
Hi, I'm Kieran Testard. I'm the member for Range Lake.
Thank you, members. And today we will receive a briefing from Health and Social Services Minister Lesa Semmler on small community model of care. Please note this meeting is being live streamed to the Assembly's social media channels. I would like to remind all members and witnesses to direct all questions and comments to myself as chair and to wait to be recognized for speaking to help us have a smooth meeting. Now I will pass it over to Minister Semmler. Please proceed with your presentation.
Thank you, Madam Chair, and thank you for having me here today with my staff. I am before you today to provide an update on work that has been completed and will be forthcoming from the review of the small community model of care. I am joined today by Alan Doody, Deputy Minister for the Department of Health and Social Services, Sarah Choroskowski, Assistant Deputy Minister for Programs for the Department of Health and Social Services, Sheena Wazuda, Director of Territorial Health Services for Department of Health and Social Services, as well as my Ali Simpson, my Ministerial Advisor, and Haley, and she is the Deputy Minister's advisor. As you know, the health and social services system continues to face serious challenges due to the national shortage of nurses. This has made it increasingly difficult to recruit and retain nurses, and it is a similar challenge for community health nurses, especially in our small and remote communities. In response, the Department of Health and Social Services, working with the 3 health authorities, undertook a review of the model of care to better understand how staffing pressures are affecting service delivery. The key findings of this review have validated that the community health nurse-led model of care continues to be the model that is used across Canada in rural and remote communities. However, other jurisdictions have been mitigating the shortage of community health nurses with the use of other health professionals and leveraging technology. To this end, the review has made 5 recommendations that I have approved to further investigate and develop plans to implement and integrate these professionals in ways of working into our health and social service system with the aim to stabilize access to care. It is my hope that this work will further support residents' access to care and will reduce health system pressures in acute care as residents can access to the care they need, where they live, everyone including in the health and social service system benefits. I will now turn it over to Ms. Choroskowski to provide a presentation on the work. Following the presentation, we'll be pleased to take any questions you may have, if that's okay with you, Madam Chair. Thank you.
Yeah.
Okay.
Thank you, and thank you for having us here this evening to provide an update on the work of the small community model. So today's presentation will provide an overview of the small community model of care review and analysis that the department has undertaken. We've done this in collaboration with all three health and social services authorities. So I'm going to provide a brief overview of the current nurse-led model of care in small community health centers. I'll discuss the drivers for this work, the process that we undertook, the results, and the resultant 5 recommendations with the minister referenced. And then I'll also provide a current status on our work towards implementation of those recommendations. Okay, so in community health centers, registered nurses working in the role of community health nurses, also known as CHINs, are the primary care providers in most NWT health communities, or in most communities. CHINs work in an expanded nursing role, providing primary care, public health, and emergency services, usually within a small team of other healthcare providers, but also sometimes independently. There are 19 community health centers in the NWT, and those operate with a complement of 2, 4, sometimes more nurses, depending on the size of the community. There are also 9 communities that are staffed with health cabins, which have community health workers, and then other care and treatment services are provided on a rotational basis by visiting nurses, nurse practitioners, physicians, typically from the regional center. The care that's provided in the community health centers is guided by the NWT Community Health Course Service Standards and Protocols, as well as the NWT Community Health Nursing Administrative Policies and Guidelines Manual. And both of those documents together help to ensure a standardized approach to lifespan care across all communities. So the small community model of care review was initiated in response to challenges in delivering consistent health services in small community health centers across the territory, where we're faced with health centers frequently or commonly on reduced or emergency services. So the national nursing shortage has led to a difficulty in recruiting qualified registered nurses to work as community health nurses in our small communities. And the role of the community health nurse is critical to the delivery of core community health services. When we have situations where we don't have enough community health nurses to deliver the regularly scheduled programs and services, then we do have health centers that are forced to reduce services so that only essential services are available. So in the summer of 2024, the minister did ask us to further try to understand the impacts of those service reductions on the delivery of care in small community health centers and health cabins. So the objectives of the work were first, a short-term focus on stabilization of staffing to ensure continuation of services, as well as the development of a longer-term vision for a redesigned service delivery model that identifies the types of professionals and paraprofessionals that are necessary for service continuity, as well as looking at the required legislative and regulatory supports. So the process that was undertaken, at first what we did was we started with a brainstorming session with representatives from all 3 health and social services and from all 3 health and social services authorities, as well as the department. And we asked them to bring forward ideas based on their experiences that they thought could support the model of care within small community health centers. And through that brainstorming session, some key themes emerged. The key themes were the use of licensed practical nurses, or LPNs, paramedics, nurse practitioners, and virtual care. So it was identified that nurse practitioners and virtual care are important enablers. However, they're not standalone solutions. The true impact of things like virtual care and the use of nurse practitioners would come from how those things are integrated into the broader team and integrated into the practice. But definitely LPNs and paramedics were something that we wanted to look more closely at. And so those themes did help guide the next phases of the work and the data collection. So to support the review, we did gather data first from the NWT Community Health Center service reduction letters, as well as jurisdictional scans and an environmental scan. So service reduction letters, if people are not aware, are a form of communication that's issued by the health authorities when they need to communicate a reduction of services, like due to rest periods or no nurses in the community. And we did review those to better understand the frequency of service reductions as well as what the most common reasons for those reductions were. And we did note that those were due to nursing shortages and mandatory rest periods. We did note that the communication tool wasn't consistently shared to the department, and so we've been taking some steps since then to make sure that there is consistent reporting of those service reduction letters. We then completed a jurisdictional scan through a federal, provincial, territorial table, which included members from all Canadian jurisdictions, as well as Indigenous Services Canada, to learn about how they are adapting their models of care in rural and remote communities. We also met with representatives from Indigenous Services Canada, Nunavut, and Manitoba, and through this we were able to gain insights into how those jurisdictions are currently using LPNs, paramedics, nurse practitioners, and virtual care tools to support their service delivery. We then also completed an environmental scan to identify broader trends and promising practices across the country. So this included looking at literature, publicly available online resources that we use to explore innovative approaches that could potentially be adapted to the Northwest Territories. So through these efforts, we found that the community health nurse-led model of care continues to be utilized in other jurisdictions in rural and remote communities across the country, but it is being provided by other providers such as LPNs, paramedics, and nurse practitioners, as well as by the use of virtual care tools. I also just want to point out that LPNs and paramedics what we found is that they are already being used in the Northwest Territories, and so we just want to recognize the significant work that has already been done by the health and social services authorities across the territory. It's just important to point out that despite the national nursing shortage, the chronic staffing challenges that are faced, we haven't yet had a situation where we've had a community health center that's actually had to close. You know, service reductions are different from full closure, and so it is thanks to the work of the authorities and their creativity in using LPNs and paramedics, as well as the dedication of existing staff, that we haven't had to face that to this point. Although those efforts have been critical in maintaining emergency and core services under those difficult circumstances, we do know that the use of paramedics and LPNs in the NWT has been inconsistent, and that their roles have been varying, their responsibilities have varied, and the level of integration across communities is not consistent. So we need to fine-tune, standardize, and formalize the use of these roles, which will include developing standards, policies, training supports, and a change management plan. So this brings me to the recommendations. So based on the findings of the review, there are 5 key recommendations that have been approved to guide the next phase of work with the goal of strengthening care delivery in small communities. So the first recommendation is to conduct a current state analysis of the use of LPNs in community health centers. So looking at where they're being used, the care that they're providing, under what conditions, and this will help us to understand their contributions and also identify opportunities to optimize their role in delivering services. The second recommendation is a similar analysis specific to the use of paramedics in the NWT. However, the difference is that currently, paramedics are contracted resources in our system, whereas LPNs are employed within our system. So same type of work, but just not on our own staff, but more around how we use them as contractors. Recommendation 3 focuses on developing a blueprint that would support the integration of LPNs and paramedics into the system. So this will include mapping LPN and paramedic competencies against current legislation and the current community health core service standards. We'll look at identifying training needs, orientation programs, and making sure that we clearly define the roles and responsibilities of LPNs and paramedics and how they would work with other health professionals to reduce risk of confusion or any overlapping of responsibilities. Recommendation 4 is to update the NWT community health nursing administrative policies and guidelines and transition them into standards. So this will ensure that the standards are reflective of the new model of care and provide clear guidance for the administrative functions of the health centers across the territory. As part of this work, we'll also develop a monitoring framework to ensure proper oversight and compliance with the standards. And then recommendation 5, this speaks to the fact that the CHIN model continues to be you know, the best focus and the primary model of care in small communities. Recommendation 5 is around emphasizing the importance of retaining and recruiting community health nurses. So exploring orientation and onboarding supports, looking at flexible work schedules, and leveraging training programs that can support the care that they provide. So of course, there's lots of work around recruitment and retention in our system. A people strategy is in development. We wouldn't be looking to compete with these efforts, but again, maybe bring a specific community health nurse lens to some of that work. And I also just want to mention that the recommendations are, you know, as I think I've stated, not intended to replace the CHIN-led model of care, but rather to support and strengthen it by optimizing the roles of other care providers. Okay, and so just a current status. So we have created a workload, our work plan. We've developed that with all 3 health and social services authorities. And although the department is leading the work, this is a shared priority across the system. The work plan, as it's currently drafted, is anticipated to be fully implemented by 2028. We are currently in the information gathering phase for the first 2 recommendations to conduct those in-depth analyses around LPNs and paramedics. And we are expecting that that work will be completed in the winter of 2026. Work on recommendation 4 to transition those community health nursing administrative policies and guidelines into standards has begun, as we're expecting that that will be complete by winter 2027. And then updates are being reported internally to our health and social services system leadership, as well as on a public-facing webpage. And I just want to make, like in closing, just state that this work that we're doing does not limit the ability of the health and social services authorities to continue to provide the care and make the operational decisions that they need to do to ensure the continuity of care while this work is progressing. And so that is all I have. Thank you.
Okay, thank you for the presentation. Now I will turn to our members if they have any questions. So we'll start with 2 questions each. Okay, start with MLA to start.
Thank you, Madam Chair. Thank you for the presentation. So your work plan, I heard the timeline for recommendation 4, winter 2027. And I know there's another one in there as well. So refresh my memory on what your timeline is, I think, for recommendation 3, but also what's the timeline for all 5 recommendations, and what's the costing for all 5 recommendations? Because if there's, anyway, it would be good to have assurances that resources are put behind this and clear milestones, so we can gauge the effectiveness of the work plan in achieving your policy objectives. Thank you.
Minister Semmler.
Thank you, Madam Chair. I'm going to turn it over to Ms. Czarkowski.
Okay, please proceed.
Thank you. Thanks for the question. So to clarify, the entire work plan, our current timeline for that is to have the full work plan implemented by 2028. The first 2 recommendations, the analysis of the LPN and the paramedic, are targeted to be complete winter 2026. Recommendation 4 is targeted to be complete winter 2027. I don't off the top of my head have the answer for the timelines for recommendation 3 and 5, but I would be happy to pass it to my colleague in a moment if that's appropriate. But what I will say just to the resources point is that, you know, absolutely having dedicated resources to help move this work forward and ensure that it does remain on timeline, that is something that is top of mind for us and something that we will be hoping to explore through the business planning process.
Okay, thank you. Okay, Ms. Sheena?
Yes, hi. Thank you. So recommendation number 3 is regarding the results of essentially 1 and 2 of both the LPN and the paramedic review, and that would happen subsequently. So the expected timeline on that is the end of 2027. And then we don't have a timeline for the 5th recommendation right now because we are waiting for the release of the people strategy, because we want to ensure that our efforts aren't duplication, but that they're harmonized with that. Thank you.
Yes, go ahead.
Just in when, yeah, sorry, yeah, and if I just may, when it comes to costing, that will come through the work that's going to be happening right now, and like, Ms. Charskowski said, like, through the business planning, we will be bringing forward those types of changes, and during this process, they'll do up the costing of what that's costing, because it's going to be positions and changing of positions, and so looking at that, we'll have to go, that'll be later. Thank you.
Okay, thank you. MLA, to start, do we have a follow-up question?
Yes, thank you, Madam Chair. So, yeah, like the actual rollout of enhanced positions in the communities will have a cost, but I mean, to do the planning work and the policy development work, often, like, do you have the internal capacity to do that and meet these timelines? Or will you be seeking, or do you need additional capacity to bring on additional help to get it done? I know this isn't a budget review, but again, it's good to have these kind of high-level recommendations, but if we're not gonna meet them because we've got staff doing a million different things in healthcare, including a people strategy and other things, this work might get compromised. So I want to be assure myself and the public that we are properly resourced for this work, so we'll be on schedule to get these things done. Thank you.
Minister Semmler?
Thank you, Madam Chair. Sarah's team is a small little army, and yes, we will be looking for additional resources, and that will come. However, the work is still ongoing. We've prioritized certain areas within that department, and so this is a priority of mine and as a government, because it is access to care in small communities. So there is a lot of going on in that department. Things are moving along. However, yes, there will be a need for additional resources to get this implementation moving. Thank you.
Thank you. MLA McNeely, you have a question?
Yes, thank you. Thank you, Madam Chair, and thanks to the Minister for the presentation that really gives strength to our small communities. I'm thinking about Cova Lake right off the get-go. And I see a huge opportunity in this area, and it really is teamwork. And to help you identify the teamwork, helping nurse Brittany, who I met in June, she is now working for us. Her and her spouse moved here in June here from Whitecourt. So we will continue to do our part. And looking at this, okay, how can we help you is my question to the Minister. Thank you.
Thank you. Minister Semmler?
Thank you, and thank you for that. I think the help is that and I think the pressure on all of us as MLAs is keeping this in the forefront, making sure that this is something that we continue to keep the gas on, because as I've said it many times, is the whole entire territory is one team. And if our small communities, like you said, Cova Lake, which is a health cabin, we have to support health cabins, health centers, regional hospitals, so that way, Stanton and Yellowknife region can be successful. So I think what you're doing now, keeping the pressure on, is actually, motivating for us to look at different ways to provide care in the Northwest Territories. Yes, we move slow. However, like I said, Sarah's team is a small little army. The whole department, they've got all different areas within the department are working on things, but it's in collaboration with our health authorities, who are the operations. And so we have to continue to work with them because, for instance, the TCSA, the Tetro Service Agency, they are a self-governing, so we have to be partners with them, and we need to support, we support what they want. So it is a collaborative approach. So I think what's happening now is just keeping the pressure on for all of us to be able to keep that momentum going. Thanks.
Thank you. MLA McNeely, do you have a follow-up question?
Yes, thanks, Madam Chair. I'm glad to see on the last page of the presentation that updates are being reported publicly on the webpage. So I plan to take this presentation out of here and send that out to the communities, to let the community of Cove Lake know that, yes, you might be called a cabin, but we're behind healthcare. So I guess I'm just trying to say this is one way I can help you, and I look forward to future collaboration. Masi.
Similar, do you want, Minister Similar, do you want to comment to that statement? Yeah.
No, I appreciate it, and I think the hardest piece, I think, in health is that we have a tendency to not want to show our work until it's all wrapped up and we can give it to you in a bow, so that because it's hard to sometimes, you're so busy doing that, to try and put something out there that's part way finished. And I think the thing is that I need us to show our work, because there's some really good work. And so when you look online, you'll see the medical travel modernization, the small and remote community. You'll see the cultural safety and anti-racism work that's going on. And those are all now going to be publicly put out with updates, and just to show where we are in the process. And I think it's just to kind of show that there's things that are going on, and it's taking a little time, but we need to do it right, and we need to make sure that we're doing it in a way that we're working with the communities, with what the needs are of the communities. I've traveled to, pretty much every single community except for 4 in my 2 years as a health minister, and listened to Indigenous governments, and listened to staff, and listened to residents. And there are themes, and those themes are what we're using to drive some of these priorities forward. Thank you, Madam Chair.
Thank you. MLA Morgan, do you have a question?
Yes, thank you, Madam Chair, and thanks to the minister and all the staff for being here tonight. My first question has to do with the use of paramedics and your investigation into that. So, out of all the different health professionals you mentioned, the LPNs and the community health nurses and nurse practitioners, so they're all regulated within the territory, but paramedics are not regulated, and so they have the least amount of oversight. Well, first, my question is the plan to investigate a model where paramedics are GNWT or health authority employees, the way nurses are currently employees, or to investigate a model where they are contracted, sort of from private companies, or both? Thank you, Madam Chair.
Okay. Thank you. Minister Semmler?
Yes. Thank you, Madam Chair. I'm going to have Ms. Chowkowski.
Please proceed.
Thank you. I think at this point, it's difficult to answer that question definitively. I think that's the purpose of the analysis work that we're going to be doing, is getting a better sense of, we know that paramedics right now are not employees in our system. They are used on a contract basis. And so what we want to do is better understand how they're being used, and how they could potentially be used, better understand how they're being used elsewhere, and then look at what would be, I guess, the pros and cons, essentially, of the different options that we have ahead of us. Also keeping in mind that there may be legislative and regulatory pieces that might be part of whatever direction seems to be bubbling to the top as the most appropriate. So I think it's too early to say, unfortunately, at this point.
Okay, thank you. MLA Morgan, do you have a follow-up question?
Yes, thank you, Madam Chair. And so can you explain what exactly is the gap that paramedics are meant to fill that for example, couldn't be filled by more community health nurses. Why are you looking at paramedics specifically? What is the gap that they can potentially fill that other providers cannot? Thank you, Madam Chair.
Okay, thank you. Minister Semmler?
Yes, thank you, Madam Chair. I think what the gap is that we do not, we have a recruitment challenge, and so we need to be able to implement other types of health professionals into our system. And we're seeing that with the use of, in the Northwest Territories has been in different health authorities that they're using them through contract. And so it has been, this is why it's been flagged that and in other jurisdictions. So it's not that they're replacing the nurse, it's supplementing the model. Thank you, Madam Chair.
Thank you. Mr. MLA Nursu, do you have a question?
Thank you, Madam Chair. Retaining and keeping nurses or even educating nurses is a big challenge, and our education system is, it's not very good if we're going to have our homegrown residents get into this field. The education system has to be improved, because probably just have a handful of potential students from the Northwest Territories who are able to take on this task of wanting to become a nurse. And is there any, are you working with the any of the other departments in trying to find ways where they can assist in this challenge of, especially with the Department of Education, and trying to find ways where we can find potential students to enroll in nursing school of some sort, to make so they can work in the Northwest Territories or even in their home communities. Thank you, Madam Chair.
Thank you. Minister Semmler, do you?
Thank you, Madam Chair. This is something that has been flagged not just by, MLAs, community. When we've talked to Indigenous leaders, we've heard this, and so we will be doing a presentation to committee on the people strategy, and some of that work is a collaboration and an overlap of multiple departments, and so that's why it fits in there. However, there is some ongoing things that we're trying to do. I know the Health Authority has been trying to do is getting students, encouraging them coming in for coming into the hospitals for different types of bring your child to work day, and a lot of different areas like that. And to be honest, I know personally the struggles. I have my own child who's in upgrading, trying to get into a healthcare field, and has their own struggles with the way that it is to get through all of the courses that you need when especially when you're coming from a small community. So these have been flagged, and we do have conversations. However, I don't, when it's, the one piece that we have is that when our students are coming out of school, they can attend, most of them in any, and I'm not Mr. Narsu MLA Narsu will say, a lot of our kids have to do upgrading, and so I know that's a piece that we can bring back and continue to have those discussions with the minister. Thank you.
Okay. Thank you. MLA Narsu, do you have a follow-up question?
Safety, our resource people within our communities, safety in the community is really important, because of all the social problems that our residents of each community is going through, especially with drugs and alcohol, the heavy drugs that's coming in. You know, it's taken a lot of time from our resources, not only the nurses, but the RCMP, the Social Services Department. They're on call 24 hours a day, and it's making a lot of it's burning them out, I would say. You know, consultation with the Indigenous governments and with the resource people. Would the department look at maybe having regional meetings? I don't like saying regional. I like community, but it's a lot of travel for a department. Just to try to find solutions on how we can combat this problem. I know the SATU is stepping up, and they're doing some good work with in terms of trying to eliminate the use of alcohol and drugs in their communities. Will the department look at having some sort of a consultation meeting with the Indigenous governments to find ways of trying to eliminate the use of alcohol and or drugs within the communities, just for safety, to give our resource people more comfort and, less stress on them on a daily basis. Thank you, Madam Chair.
Thank you, Minister Semmler.
Thank you, Madam Chair. And thank you for that. I believe that yes, one of the pieces that we're looking at as during the presentation, that with the call outs, the nurses are on call, and then it results in closures because they get called out in the after hours and they have the mandatory rest period. And I think that's an important piece why we're looking at implementing other people into the community, because then the dedicated staff that would be there for health promotion and dealing with those things would still continue to run those programs, even though the emergency pieces. But what you're talking, with regional meetings, we do have the Regional Wellness Council chairs, and I have, since I've become minister, we've changed the way that we met. Prior to my time, I talked to many of the Regional Wellness Council chairs. They met with the CEO, they met with the deputy minister, but there was never a time to sit and have meetings with the minister. So we changed the way, once we put the public administrator in place, he meets regularly with them as the governing council always met. However, we now have twice a year minister chair meetings. Some may kind of remember, know those through the education minister meetings with their chairs, regional chairs. So when we have Regional Wellness Council people in the communities, they bring forward those issues, and so we come to solutions with that. I've also had bilateral meetings with most Indigenous governments, and we have conversations with how to work together. And so, although I'm not flying in with my team to every community, we are having these regional meetings with leadership, with regional wellness chairs. We also have the Indigenous Advisory Body that has appointed members from each of the Indigenous groups that meet with our department in the cultural safety and anti-racism. So they work with them on policy. And so there's many different ways Health and Social Services engages. And I also, as the minister, I've made it a priority to make sure that I did go out to all the communities, listen and have community meetings. And then we take back those concerns and my staff and, turn those into some of the work that we're doing and even amending some of the work that we're doing. Thank you, Madam Chair.
Thank you. MLA Yakalaya, do you have a question?
Yes, I do. Thank you, and thank the minister for the presentation. I'm really happy to hear that the CHRs and the health cabins in the small and remote communities will be getting further training to support people in the small communities, because building human resources, the people that live there and will stay there is a good investment. It's a really good thing to do. Um, what does this what does the training plan look like? What type of training will CHRs get? Thank you.
Minister Semmler?
Thank you, Madam Chair, and thank you, MLA Yakalaya. So the work that's happening in the health cabins is part of the primary care reform that we're doing. That's another piece. That's just, so there's multiple things going on in small communities. So in the health centers that have nurses, that's the model of care that we're working on. We call it the Det'anchogh journey, and I did a member statement on it, and I just recently went to the Nahende and was able to meet with the 4 health cabin communities, and we heard from the community wellness workers that are in week 12 now of their training. They're learning all types of skills. Like before this training, they had no formal type of training. They worked in the health center, and in these communities, some of them haven't seen nurses or health professionals in one, there was up to a year. So they're the only person in that community, and so what we've been doing is expanding their scope and working with them to see what they want to do. And so the Northwest Territories Health and Social Services has gone in there and done some work on the health cabin side to put more support, and so that I think the training is basic. Like there's they can do vital signs. They are now trained to use the equipment in the health center, like the oxygen, and they are able to, they were trained on the AED. They are training on all of the medication and ordering the medication. They now have access to electronic medical records where they didn't before. They're learning to do point of care testing, so pregnancy testing, I think glucometer testing, urinalysis. So that way when they do call the nurse, because there is no nurse full-time in that community, they can do some of these things prior to, or they can go on and have an appointment virtually with the nurse, and then they can say, can you do these things? And they know how to do them. So it's just another tool for them while they're in the communities. And now we have a dedicated nurse practitioners that are going to be going into these communities and spending a week rotation in each one of the health cabin communities in the Nahende. And then they'll be virtual. So those residents in that community will now know who their nurse is, and when they're not there, they will be able to have virtual appointments with that same nurse. And so that is new, and and they were very pleased to be able to have dedicated staff going into that community on a schedule. But the other part of it is that training was because of the Det'anchogh journey, and we have 9 health cabins, so any other health cabin community wellness worker has been able to take part in that training. So there is other, like in Sigachik we have one, in Colville Lake we have a health cabin. So they've been able to take part in that because it's online training as well, to expand their skills. So that's some good work that's going on for the health cabins. Thank you, Madam Chair.
Thank you. MLA Yakalaya, do you have a follow-up question?
Yes, I do, and I really appreciate that. That sounds like that sounds good. I'm glad there's movement in that area, because before it was, there was a lot of concerns from people. And the other question I have is, are these healthcare representatives in these health cabin able to send people out for mental health or addictions treatment programs? Like how does how does that work? Because I know in the smaller communities, there's such a challenge about, because they don't have a mental health worker that is readily available should there be an emergency situation happening in little communities. Are they and are they able to access medical travel, or how does that work? Just so I could give some information to people about. I've had an instance where I've had a mother come to me and say, this was happening with a family member of mine in our community, and there was nowhere to turn. So the person that is working for us is not trained in that area, and um, I really didn't know what to do other than to call the RCMP. So safety is a real issue in small communities, especially if something like that would happen with like an incident would happen if there was somebody drinking, or there's drug use in the small communities. How do they work to get people out for treatment or to get them out for help? Do they access medical travel? Just like kind of like a step, what happens next? Thank you.
Thank you. Minister Semmler?
Yeah, thank you, Madam Chair. So within within the health cabin communities, I think the piece that we're recognizing, and that's the thing is that there was limited training for those workers to be able to assist in many different ways. And so what we heard from the community when we were traveling was that they'd have to call Fort Simpson, for instance, for everything, unless the clinic was open in the afternoon, or if it's a half day, because the wellness worker only works half days in some of the communities. So there are challenges, and those things are going to be looked at as well. However, with the dedicated nurse practitioner going into those communities, they'll be better. These communities are from 70 to 100 population. So with this dedicated nursing going in and spending, because normally what would happen is they go in for a day and they'd leave. And that was it. And then you might see them a couple months later. So now they're going in, they're staying in the community for an entire week. So they'll be able to do case management. They'll be able to, work with the health community wellness worker to set up protocols in those communities on what needs to happen when this happens. If there's a mental health crisis, what do I do? These things haven't been in place, and this is something that is important, that needs to be done. And so that's why I've directed the public administrator to make sure that this is started there. Like I said, I've traveled to most of the small communities now. And this region, we just recently traveled last week to, has really highlights and shows that there's so many gaps in there right now. And so the work that's going on in there is so important to be done. So I'll just leave it at that. Thank you, Madam Chair.
Thank you. Thank you. I do have a question too as well. We've come a long ways, and in June 2023, we passed a motion, and you were part of that. You were a regular MLA, and we did pass a motion. We put a motion forward to improve the healthcare system in the NWT, especially small communities, because we had a lot of issues where Tylenol was overprescribed, especially with our vulnerable members, and most of the time, some of our people were diagnosed late in stages, and Tylenol was used for everything. So from that, it does. I really do appreciate, and I know that the department is making an effort. And you are aware of it too, so which is good. I really do appreciate that, So I really do appreciate that. It's good in a way to give some comfort to our residents. But everything is okay. I mean, not everything is okay, but it's just that, I know a lot of, we still need to make some improvements. And a lot of topics that you've covered, and which is good. And I know that, I think I saw some of those were being used in other communities. For example, in Cleacher region, in Bet'anchogh alone, we had staff, ambulance drivers, doing blood work. And that was good. I know that, I know some of the elders were comfortable getting, having their own ambulance workers doing blood work. And because I can tell you, my late mom was one of them too, and she really appreciated the work that they were doing. And so it's good. We've come a long ways. That's why I said we've come a long ways. But some of the stuff that we're working, it was taken away. Why did that happen? Because I know, I am not too sure if we're still using the ambulance worker, but, to help the burnout stages and to relieve some of the work of the nurses, I think they were doing, I think it was, they were doing more. So I think it gave some relief, but I don't know how the nurses felt, but it did help. So I just, then that's another career for our Indigenous. It's different from the paramedics. The paramedics that we have, contract, you said, these are not our own local. These are from somewhere else. But our own locals, I think, that have, the culture and the language, so they do identify with the people. So I just wanted to know if any of the small communities, well, you identified there's, 19. So it's all small communities, and the larger regional centers are left out. So this is for the small communities. So and Bet'anchogh is part of that 19 communities that you mentioned. So, and Wokwiti too. So I just want to know if not just my region, but other region as well, because this is good for employment and training opportunity. So if those ambulance workers, if any agency have the ambulance workers, are they being trained to help the nurses with the blood works and other stuff? Thank you.
So, thank you, Madam Chair. That level of detail I don't have in all of the communities. I do know that in all of the health centers, yeah, nurses can draw blood work, and paramedics, and they can be trained and be certified to do those types of things. And so even with those community wellness workers, that is on the list. However, I think where they are right now is they just want them to have the initial basic skills. Don't want to overwhelm them and give them all of the things and then add on drawing blood and everything on top of that. So I think where we are right now is they're implementing a skill a week, and then they're following back up with them they're going to be, once they're done, I think it's 24 weeks of training, I believe, then they're going to follow back with all of the community wellness workers in the home, because some of them are home support workers that are training as well, so they can help relieve each other, to see where they're feeling like they still need more, they need more support and more training. And then they're going to have the staff educator go in and do some hands-on training with them. So that's coming up, I think, in the new year. And so they'll be bringing them, I'm not sure if it's to Simpson and bring the community wellness workers in and do some, first aid and other training. However, the blood, there was talks of, certifying them and drawing the blood, so that way when the nurse is coming in, they can draw the blood, they can send it out, so that way when the nurse is coming in, she's got all the blood work, or before the people have their appointment, they can. So, but those things are gonna take a little bit of time, because we don't wanna overload them with all these skills, and then they get scared and run away from us. But they're really appreciative of all of the new skills they have because they feel like they're able to do more for their community, so.
That is true, and then, like it's not just now, but we heard it in the 19th Assembly as well, that some of our people were diagnosed in late stages. And that was like a concern for a lot of us. And so I know we have X-ray technicians and we have X-ray machines in most of the communities. And I think if we had an ultrasound equipment or staff trained to do ultrasound in small communities, I think maybe that would help a lot for our community members instead of waiting last minute. And so I just wanted to ask, because that is also, I think you did mention about that too as well before with your daughter was going into that one of those fields. And I heard from some of our community members too, young girls, young people, that they did ask about that too as well, because they see those courses are being offered in South at NATE and SAIT and then some of those colleges and universities. So they did ask about that. So I just want to know if that department is extending some of these services to small communities with population over a certain amount, like maybe 500, 400 or 500. Because, like Delnay, that's like over 500. Petchico is over 500 to provide extra services to the staff. Because we do have, many of our people are X-ray technicians in the small communities. CHR can do those, some of those jobs too as well. So I just want to know about that, if some of those trainees or some of those services can be provided in small communities. Ultrasound technicians. Thank you.
Thank you. And it is kind of exciting because some of the virtual things that we are looking at is realistically today, the challenge of getting these sonographers that are trained technicians into the communities. But what we do have the opportunity, and we're looking into this and it's being explored as part of the virtual toolkit, and is being able to train the wellness workers and having the nurses trained where because even as a nurse, you're not trained as a ultrasound tech, but you can be trained to use some of the tools where you have an ultrasound tech somewhere else and you're using the equipment and they're actually being able to read the ultrasound. And so we're exploring some of those virtual tools right now. It's like the X-ray. You can take the picture of the X-ray and be trained to take the picture, but then there's somebody somewhere through our PAC system can read the X-ray and make sure that it's a good picture, or you can have to go back and retake the picture, but you have to be trained in order how to take the picture. So that's one of the things that we are looking at is some of these virtual tools that they have now to be able to, I think the community wellness worker have the virtual stethoscope, so they can put the stethoscope on, and the nurse, if they're on the clinic virtual, they can listen to their heart and their lungs and everything, and they could be in Simpson or wherever they are. So there is more tools that we're trying to implement into these smaller communities, because realistically, you're not going to get a sonographer to go into all these communities. Then we're going to be sending people out. The goal of this is to be able to do as much at home as we possibly can to not have to travel, because people don't want to travel unless they have to. Thank you, Madam Chair.
And I think Mr. Mary Tester have a couple of questions.
Thank you, Madam Chair. So why weren't service reduction letters being shared with the department? You mentioned in the presentation that they weren't always being shared, but what was leading to that kind of breakdown in communications? Thank you.
Okay, Minister Semmler?
I'll have Sarah.
Chirikowski?
Chirikowski.
Chirikowski.
Thank you. I don't know if I can say a specific reason why. I think we were getting them from some regions and communities and not consistently from others. And so it's probably not anything intentional. But we have, since we've discovered that we're not getting the full sum reporting, we have had communication out with all three authorities to let them know that as part of this work and as part of like our ongoing efforts that I mentioned towards monitoring, that there is, you know, a reminder that has gone out to folks that those do need to be sent in to us so that we can track those things. And it supports this work, but also just our overall oversight role.
Thank you. You have a follow-up question?
Yeah, I guess my concern around this is, you know, also with recommendation, the work of related to recommendation 4, where you're taking kind of policies and guidelines that have been in place and actually turning them into standards. You know, the service reduction, that should be part of it as well, obviously, that you have kind of a standardized for the information flowing. But, I mean, then we talk about paramedics and how they're unregulated and they can, you know, they have certificate or they have credentials from other jurisdictions that are maintained by their employers that we don't have anything to do with. And, you know, and then in municipal circumstances, it's a completely different kettle of fish, but we won't get into that because it's not related to your responsibility. But it just feels like this is a real Wild West situation, right, in community centers. And it's good that we're taking a look at it, but this plan, I guess my overall feeling with this plan is you're doing a lot of investigations, you're not doing a lot of actions. And we know the problems have been persistent for a long time. You've mentioned this or the minister has mentioned this as a driving force for her ministry. And why aren't we moving faster on this? The comment was made that we'll move slow and we'll do what we can, but you know, the acute care issue or the acute issues in the healthcare system are not getting any better, and you know, the focus has been pulled a bit because we're focused on, like, there's some other major issues like the economy that we're dealing with, but I agree with the minister that this is a real centerpiece. And if we don't fix the issues in the smaller communities, it puts additional pressure on the larger centers, and particular Stanton, which is, you know, teetering on the edge quite often. So, all that being said, you know, we have this Wild West situation, seemingly, where, you know, it's unclear how things are working because there aren't clear standards and guidelines. We have professions that are completely unregulated, and we have an action plan that is mostly about investigating. So when will the actual actions to deal with these things be prioritized? Because we need to fix these issues before they add to the more acute issues that we're seeing in the healthcare system. Thank you.
Minister?
Thank you, Madam Chair, and I appreciate that because, you know, I feel like as I've been traveling through the communities, the small communities, they're the forgotten land, and I'll be honest, because we have seen the shortages. We have, you know, this is something that's gone. Even before COVID, we started to see that we were not getting as many, you know, full-time chins into the communities, and it's a change. It's a change in our, you know, how people choose they want to live and work. You know, it's not the same as it was 20, 30 years ago. We have some of the nurses, and I just traveled, and we seen a nurse that's been going to the same community for 30 plus years. But she is a rarity. There isn't very many of those nurses that are doing that anymore. And even with her, she lived in a small community for 20 years, and she does the job share. That's the issue right now, and that's why we're prioritizing this work, and that's why I have made it a priority to make sure that we are get the policies in place, because if we don't do the analysis and we don't get the policies in place, then, you know, I mean, Ms. Whalen Armstrong said, how are the RNs feeling? Like, if nobody knows what their role is in this health center, because we're just implementing it and we're not doing the analysis, everybody needs to know how they're gonna work together, who's doing what. If LPNs, and LPNs have been unregulated in our system for many, many years until they became regulated under CAN. They worked under policies and stand like within every region that had LPNs until we pulled them under CAN. So this is the work that's going to be done. Paramedics are not something that this is just kind of, I think the Det'anchogh has used them, but it's because of the shortage. And then we've had a contract over the summers for forestry that we had to pay a fee and have paramedics on standby, so when there was a fire or a community evacuated, they would be automatically ready to go. What we were seeing is that when, in the summer, when there's fire, there's also less staff going into communities, so when it was a 4-nurse station and we had only three nurses, we could pull the paramedic that's been on call over there to kind of help and do some of that initial triaging and assessment. And that would help the nurse so that they're not being pulled out of clinic or the well child or all of the other, their programs that they have to run. And so this is a priority, and this is the work that we're doing. It is multifaceted. We're working with authorities. We're working in all our different communities, and they all have different staffing models in all of the communities. Thank you, Madam Chair.
Okay. Thank you. Do you have a follow-up question? Okay.
Thank you for the indulgence. Yeah, and that work is going to be implemented 2028, the investigatory work, and then presumably resourcing would come afterwards, and presumably people would start to see a difference in the quality of care 29, 2030. And I think if we have a crisis, we need to be working on shorter timelines. And if we're talking about like RNs as well, so you in the presentation, and the department has mentioned this many times, Madam Chair, but there's this national shortage of nurses that is driving our territorial shortage. But I would say that there is a more acute territorial shortage, because as the minister just said, the conditions of the profession are very different now, and you see, or we've seen less of a desire to actually stay in communities. But that being said, that's not a reason why we can't solve those challenges. We should be creative about incentivizing ways to solve this. But are we being told, with this national shortage of nurses, is it just that when we try to recruit, no one's signing up? Or is it that they're all going to Yellowknife or larger centers? Or is it that they're telling the authority, no thanks, we'd rather work for agencies as travel nurses, or we'd rather work in other jurisdictions? Can you clarify how the national shortage is impacting our recruitment and retention? Thank you.
Thank you. Minister Semmler?
So where we are right now is that there isn't a lot of nurses out there to recruit. And so being able to be flexible, and this is kind of the pieces where we've heard from staff to be more flexible, and that's more geared into how do we do business with not being able to hire full-time staff all the time. And so I want to be clear that even though this work is going on, that we do have LPNs working in health centers now. We do have paramedics being implemented into some of these health centers now. So we are adding and doing different things in different communities as we need, so that way we do not impact or, worst case scenario, have to reduce services to where we have to close a health center. And we've had to do, to do that. And sometimes we have other professionals that come into the community that have a spouse that is an LPN or is a paramedic. Then we try to leverage whatever they are and implement them into our system as it is now. And all of this work is feeding, like even those pieces when there's just people in those communities that have this skill set, that will feed into the work that's ongoing. So thank you, Madam Chair.
Thank you. Thank you, Minister Semmler. I do have a question as well, too. Clitro paramedics, I'm very amazed with the work that they do. I'm proud of them. That's what I have to say. I'm proud of them because I've seen them in action. I've seen them, how they are really in tune, and it's just really amazing, So, but that's in Clitro region, and I'm not too sure if there's other region that have the same, where it's indigenous, not the paramedics from outside, but they're working. I know they are probably working with the paramedics, but the work that they do, we have to compliment them because we do rely on them as well. And they're the first responder too. And but I don't know if those kind of services are available to other communities or if they have the training. I know that they go through an intense training at the beginning. And what we really need to is that, and I've said it before, I've said it to you too, is a mini hospital. If we had mini hospital in South 2 region or in, Clitro region, I think a lot of the services, we could eliminate some of the burdens, to the healthcare in Yellowknife. But everything, we go through Yellowknife, but we do need some kind of a center like that where, it's a stop for, that we can do a lot of things within that area. And with Wigwati, they do have a health center, and I talked to you about it too, but, and I will send you an email on that too as well, because I was talking to some of the people there. The health center is in a community government office, and it is uncomfortable for both sides of staff or for the patient going in, because it's in the community government office, and especially when things do happen, and there is some uncomfortable feeling. So they did ask, I know that they need their own health center, a standalone health center. So I want to ask, how many communities of those 9 health center or cabin that you're talking about here, health cabin, or how many of those are standalone health center, or is it shared in an office building, or? Because you said there's 19 health center, and I'm sure that's like standalone health center, and there's 3 in my region. And so so how many of those are standalone, and did any of those regions request for a health center? Because I know Wigwati needs a health center. Thank you.
Thank you, Madam Chair. I don't have that level of detail. I do know the health cabins that I have recently gone to, they were standalone, or the health cabins. 2 of them, I believe 3 of them that I just traveled to were, one was a lease off of the Indigenous band. One is brand new in Samba Cay, and it's standalone. Well, it's newer. Fort Wrigley is a very old health center, and Nahanni Butte is it was an older health center as well, but those were government, I think, owned. Other than that, I know Sigachik has a standalone health center or health cabin that is government owned, and that one is up for a planning review, a planning study. The one in Jean Marie is the one that I said that the Indigenous band owns. And the Kikiza, the planning study for the Kikiza Health Center, because there isn't currently one. I think they use an office space in the community because the community is so small. So, thank you, Madam Chair.
Good. Thank you. And ambulance workers, does any of the other small communities have their own ambulance? I know my colleague here, Ms. Yakalaya, MLA Yakalaya, was inquiring about that too as well, the ambulance workers. But we need to go to Wukati, me and you, and visit the people and visit the health center, and then you will know what we're talking about. Thank you.
Thank you, Madam Chair, and I accept your invite, so whenever you want, just let me know and we'll coordinate that. I believe with the paramedics that's been implemented into the Det'anchogh region, that is a unique to the Det'anchogh Service Agency, as they have done some unique things in their region. I think they have done some more work in hiring public health nurses and using different skill sets throughout their communities. And so that work, and that's why we're working with those health authorities. And those are the pieces that we learn from, and then we implement in other areas where we see there's a gap. And I just want to, to add to that is that there is ongoing work implementing new things into areas where there is a need. And as I mentioned today, the nurse practitioners that have been hired, this is totally new, has never been done. They're working. And their job, there's a position, they're job sharing, so they'll work 8 weeks in, and 4 weeks will be in the health cabins, and then 4 weeks will be in the region, and they'll be virtual. And so it'll be 2 nurses that have been community health nurses in the region, and they went away and became nurse practitioners. So we're implementing nurse practitioners to these smallest communities, and so they can, they're even more advanced skills than the advanced practice chins that we currently have. Thank you, Madam Chair.
Okay, thank you. Okay, Ms. Yakalai has a second set of questions. Ms. Yakalai, MLA Yakalai?
Thank you. Thank you, Madam Chair. My question to the minister is, when you talk about paramedics, will paramedics be trained in, like, say, the Det'anchogh region? We're right on the highway, and the one highway that comes into the Northwest Territories, we have people in Enterprise, Kikisa, along the Kikisa, as well as Fort Providence, that leads up to Yellowknife. Should there be a major incident in either of those communities, we need people that are trained paramedics. So is there a plan to train people in the community, or are you going to contract paramedics to be in those communities for those health cabins? And the ambulance too, we need the ambulance services in that area, because should there be, like, again, a major, we don't have an ambulance, and so that is sorely needed that route, like for Fort Providence, even Kakisa and Enterprise, like, so those resources are really needed in the community. So my question is, the paramedics, will you be training people in the communities, or will you contract them out? And when will that start? Because I've had a lot of questions, like a lot of my constituents asking me about that. It's for safety. They're concerned about the safety and the overload on the nurses too in the community. So that's my question. Thank you, Madam Chair.
Thank you. Minister Semmler?
Thank you, Madam Chair. So when we discuss paramedics, there's different level of paramedics, and so what we're looking at is in the health center utilizing paramedics. But there is also work going on between myself and Minister McKay with MACA on bringing forward some discussion paper on first responders in the community and how, like, community transport to the health center. So that way, if we have trained responders, so there'll be some more work on that. However, like the ground ambulance services, that doesn't fall under, outside of the health facilities is not where our mandate, it ends, and so it becomes MACA. And so communities, you know, that's a question for MACA.
Okay. MLA Yakalaya, do you have a follow-up question?
I didn't hear the answer about the, I was writing things down, so I didn't hear the answer. Sorry, I didn't hear the answer about the trained paramedics. Is that something going to be trained in the community, or are you going to be contracting them? Thank you.
Okay. Minister Semmler?
So we're not going to, it would be first responder training, and that's, I think that's something that already lies within MACA, and that's why we're trying to collaborate with them. And so how do we, because we've heard from many communities, when there's an issue or when there's an instance or there's an emergency, the nurse, you know, cannot leave because her profession is to take care of them within the services and the tools that she has in the health center. So it's working with MACA on a plan for training first responders in the community. That's not necessarily the level of paramedics. It's more of training them so that they can stabilize and bring to the health center. However, even with the implementation of what we're doing, once we get to that, it's, if we go down that road, it would be in the work that we're going to be doing to review how we would, if we're hiring them, you know, we wouldn't be training them. Like the health department doesn't train on the job, these types of professions, but we'd be looking at options on how to implement them into our system and within our health center, and what the credentials would be and what their jobs and what they would be doing in the community. Thank you, Madam Chair.
Okay, thank you. Kieran has one more question. Yeah. I mean, MLA Tester. Sorry about that, I do apologize.
That's all right. We're all friends here. So I'm even if you complete this work, when you complete this work, I shall say, you still have a resourcing issue, which is if you don't have the staff to go and to fill the position, or sorry, if there's a shortage of the personnel you need to fill these positions, then doing all the work to make sure you've got a standardized profession and all that stuff in place, you're still going to be challenged by those shortages. And those shortages are driving us towards using more private medical services. So we have, you know, private care paramedics, we have private care travel or agency nurses. There's a lot of concerns I have heard from professionals in particular, so frontline people who are doing this work, that it sounds like we're privatizing care. And so my question for the minister is our public health care system under threat of privatization? Based on the inability to recruit the medical personnel we need, in particularly in small communities. Thank you.
MLA, Minister Semmler, please.
Thank you, Madam Chair. We don't use agency nurses in health centers. We haven't, as long as I've been as the minister, that I don't believe that there has been any agency nurses. We do have casual contracts that we hire, and they come in and they do, some do job shares, some do contracts, short-term contracts to come in, and they do multiple, so they return over and over again. However, those aren't agency nurses. They get paid the same as the rest of the nurses in the facility. We haven't had because health had to hold the contract for the paramedics for the forestry in case of an evacuation in a community. That's when we started. They were there. We needed a staff. We started to try to utilize them just to help. But that is why the work that we're doing is we want to implement them into the system. And so how do we implement them to the system and hire them into our system and not be utilizing this? And one of the pieces that I would like to say is the LPN, not necessarily going to be in the line of the emergencies. So we need to do more. We need to do more in our communities on health promotion, and we've heard that from all of our small communities. They want people dedicated, so we can assign duties and roles to the LPN to be overseeing a lot of the health promotion, to make sure that it's being done, and overseeing the staff that work under them, making sure home care is being carried out, chronic disease management. We need to get some staff that are dedicated to that. And so by changing this model of care, and yes, we're going to have to implement new staffing into these communities. However, we do have a lot of nurses and local nurses that are going through the LPN program, and we continue to have the LPN program. There's a new cohort that just started in September. There'll be an intake again in 2027, so anybody who wants to be an LPN in the Northwest Territories, train in the Northwest Territories, the Aurora College has that program. We have the nursing program. There is a bridge-in program, so if you are an LPN to be an RN, we've tried to, make it as easy as possible. There's courses they can take prior to going in full-time for personal support workers. That's our home care workers. There's many things that the college is doing, and we are collaborating with them, and we're getting federal funding to pay for some of these programs. So we just need to make sure that, and as MLA Narsu says, we need to make sure that our kids are getting through the school system, and then we are supporting them through these after programs, so they can go back home and having that, I think, transition from their school back into the community. And if they want to go into a smaller community, what is that plan going to look like? And that is a lot of the people strategy ideas that we've heard, that we put forward towards to that. So thank you, Madam Chair.
Thank you. The department is doing a review and analysis of small community model of care. In Klitschko region, we had a hospital, and we had a cottage hospital. And now, can you make the mini hospital part of your research? Thank you.
Thank you, Madam Chair. At this time, it's out of the scope of the work that we are doing, and we're taking the lead with Klitschko Service Agency as what they want to do and how they want us to support them from the department. Thank you, Madam Chair.
Okay. Cheryl? Amelia Kalaya.
Thank you. Thank you, and thank the minister and her department. Even though we are faced with a lot of challenges, and by working together, we can find solutions to how things work in our territory and specifically in our region. That's why I always wanted you to work on health promotion, because, if we had more health promotion on nutrition, self-care, drug use and its effects, sexual health, pregnancy, mental stress, the safety issues for seatbelt safety, ice and boat safety, things like of that nature, then we'd have people that, would be able to take care of themselves rather than always depending on, they would know what to do in certain instances. So with that, I want to say thank you, because in one of my communities, we recently got a CHR, and there's been some really good things happening in the community. The kids are now knowing what the effects of drugs are in the schools and in the community. Their radio announcements, and they're doing, this young person is doing some amazing things in our community to help people to get educated on things like nutrition, what to eat, and because we always say you are what you eat. So, and how to take care of yourself if you're dealing with a mental stress, so, and there's ways to deal with these things, like going on the land and doing certain things on the land, because you're dealing with predominantly Indigenous people in the smaller communities. You have to think about their way of life and how that could benefit them rather than hinder any of their health issues. So because using that, so for just in saying that, I just want to say thank you. And we are faced with many challenges in the Northwest Territories in regard to health. The addiction crisis and the drug crisis is out of hand in some of our communities, and people are at a loss as to what to do. So those um, health promotion things, activities in the community really makes a difference. So with that, I would just wanted to add that as get the posters out there, get the little flyers and things like that, because that's what helps people. That's what helps to educate people, and people are becoming in the know about how to take care of themselves. Then we wouldn't have so much pressure on the healthcare system. But as it is right now, with the crisis we're facing in the community, and the small communities really do need support. So thank you for taking that initiative to make that a priority for your department. Thank you.
Okay, thank you. Minister, do you want to respond? I think it's more of a comment, but do you want to respond? No?
No, thank you, Madam Chair, and I'm a true believer of health promotion, and I think Cheryl, my MLA Akalaya, as she has consistently has raised this issue, and and it is important, and so we will that, and I think that's the whole part of it is making sure that there's other pieces in these small communities, other people, other staff, other health professionals, so that way it's usually the health promotion and all of that stuff that goes to the side when we're just dealing with crisis and emergency, that the current staffing models are not able to always dedicate to that. So we have to ensure that we make sure that there's a line, and that's what this work is going to help, is that the staff that are dedicated to this cannot always be pulled into the emergencies and things like that, because this is just important, because we are where we are because we haven't focused on making sure that this has been done. And so that's the chronic disease management, making sure that people know how to take care of themselves when they have a chronic disease. But the piece before that is preventing that chronic disease. And so I've heard it from many small communities, especially with the high rates of diabetes, is many community members don't even know, like, what and how do I eat healthy. And so now we're hearing from Indigenous groups, because they get a lot of health dollars, so they've been targeting diabetes in a lot of the communities. So I know recently we were just in Fort Simpson, and the Det'anchogh Wellness Department has created a cookbook that's all cultural foods, and it's all diabetes, so to help with eating healthier. Thank you, Madam Chair.
Okay, so we've been talking about small community model of care. So I just want to know, did any of the doctors, or did anybody reach out to see if they would like to be stationed in the small communities, or to work in the small communities, or to be a physician in the small communities? Was there any, because I know that in my region people have been asking about that, so I just want to know. Any region. Thank you.
Thank you, Madam Chair. In the health centers, I think the most responsible health professional is the CHIN, so it's usually the NIC. Sometimes we have nurse practitioners, and they also share the role of NIC. We do not utilize physicians in the small communities full-time. So what they are is, if they do go to the small communities, they're traveling in and running clinics into the small communities. And that's been the practice for a long time. However, with the lack of physicians, we're looking to utilize different models, and that's why in the health cabins, trying to implement nurse practitioners is something new. And so we're looking and we'll be monitoring how that works and how it improves, because they'll be able to manage the client, the patients and the residents in those communities, and have a better feedback for us, because right now there isn't a lot. So, thank you, Madam Chair.
Thank you. I want to say thank you very much for joining us today. So this concludes the public briefing on small community model of care. So thank you for joining us.